Hi, my name is Cindy McGeary, and this presentation for the Virtual Clinical Lunch Series will also serve as my presidential address that normally would have been at APS. A little bit of myself. I am a psychologist at UT Health San Antonio. I am also a veteran, having served with the Air Force. My time at UT Health is split between running the psychology internship training program and research. My primary research areas include chronic pain, to include post-traumatic headache and the treatment of PTSD with veterans and active duty service members. Thank you so much for being here today and listening to me talk about post-traumatic headaches. I will be discussing post-traumatic headache, taxonomy, and behavioral treatments with primarily active duty and veterans. I will also focus on some of the outcomes of a large randomized controlled trial for post-traumatic headache that my husband and I conducted in San Antonio that is focused on behavioral treatments for post-traumatic headache, which is why you also see his name on the title slide. He was the primary PI and I was a co-PI. Thank you for being here. So here's an overview of what we'll talk about today. We have taxonomy of post-traumatic headache to include definition, prevalence, classification, and assessment. We'll also dive into the randomized controlled trial for post-traumatic headache and post-traumatic stress disorder that we conducted to include an overview and study findings, and then end with conclusions. So first off with the definition. The International Classification of Headache Disorders, 3rd edition, was updated in 2018. The diagnosis of post-traumatic headache is different than other headaches in that it is diagnosed based upon the presence of head trauma that is defined as a structural or functional injury resulting from the action of external forces upon the head to include impact between the head and an object, penetration of the head by a foreign object, or forces generated from blasts or explosions rather than the symptoms that are present. Post-traumatic headache is considered a secondary headache because the headache is considered secondary to the trauma or injury. The headache can be a new headache that first occurred in close temporal relation to the trauma, or a pre-existing headache that has been made significantly worse due to trauma or injury. Post-traumatic headache is considered the most common secondary headache. The ICHD criteria states that the headache needs to occur within 7 days following the injury, or within 7 days of regaining consciousness, or within 7 days of being able to sense and report pain again. The authors of the ICHD acknowledge that the 7-day time frame is somewhat arbitrary, but there was not enough evidence prior to its publication in 2018 to suggest a change to the 7-day criteria. However, our city group has recently published data that refutes the 7-day criteria, and we will discuss that more in the presentation. Post-traumatic headaches can be classified as either acute or chronic. Acute post-traumatic headache resolves within 3 months, and chronic lasts longer than 3 months. And once the headaches last longer than 3 months in duration, they are considered persistent post-traumatic headaches. There are further diagnostic criteria based upon whether the head injury is considered mild, moderate, or severe. These include the criteria from the previous slide, as well as one of the following symptoms from the list for moderate and severe traumatic injury. And these include a loss of consciousness that is greater than 30 minutes, a Glasgow Coma Scale score of less than 13, post-traumatic amnesia lasting greater than 24 hours, an alteration in level of awareness that for greater than 24 hours, and imaging evidence of a traumatic head injury. And the mild traumatic injury group cannot have any of the first 5 from the moderate to severe group, but must experience one or more of the following: confusion, disorientation, impaired consciousness, loss of memory immediately before or after injury, and 2 or more of the following: nausea, vomiting, visual disturbances, dizziness and vertigo, gait or postural imbalance, and impaired memory and concentration. These last 6 symptoms are often commonly accompanied with fatigue, psychomotor slowing, insomnia, anxiety, personality changes, and irritability. When several of these symptoms occur after a head injury, it's commonly referred to as post-concussive syndrome. talk about prevalence. Post-traumatic headache is the most common after a mild TBI, and that's in comparison to moderate or severe TBIs. 11 to 23% of service members have suffered a TBI since 9/11. That is approximately 330,000 to 690,000 individuals. Post-traumatic headache is highly prevalent among military service members. 90% of acute post-traumatic headache will abate without intervention. 60 to 60% of veterans experience persistent post-traumatic. Persistent post-traumatic headache is prevalent among military veterans with TBI, with up to 97% reporting headache after injury. These veterans often experience higher unemployment rates and decreased activity levels even 10 years post-injury, which really shows a need for an effective treatment. There are many things that may contribute to the development of post-traumatic headache, but causes at this time still remain unclear. Axonal injury, alterations in cerebral metabolism, neuroinflammation, alterations in hemodynamics, genetic predisposition, psychopathology, and patient expectations all may play a role in the ultimate development of post-traumatic headache. Recent research has found that sleep disturbances, mood disturbances, and post-traumatic stress disorder, along with psychosocial stressors, could play a role in the development and persistence of post-traumatic headache as well. Mechanisms for post-traumatic headache within a military population also includes peripheral tissue damage, inhaled particulate matter, and barotrauma, and overpressure due to blast exposure. The last risk factors include a previous history of headaches, a less severe injury. As I already stated, individuals are more likely to develop post-traumatic headache after a mild traumatic brain injury than a moderate or severe. Female, and the presence of comorbid psychiatric disorders such as anxiety, depression, or PTSD. I'm going to move on to classification. 90% of all individuals who sustain a concussion will experience post-traumatic headaches, and headaches are often one of the most persisting complaints that are rated as moderate severity or higher. Most post-traumatic headaches present with migraine-type symptoms, but up to 1/4 of post-traumatic headaches are also characterized as tension-type headache, and a minority are considered cluster headaches. The Global Burden of Disease study in 2015 ranked migraine as the third highest cause of disability worldwide for both men and women under the age of 50. Migraine has two major types, migraines with and without aura. The difference between the two is based upon the presence or absence of transient neurological symptoms that precede the headache. Migraines are generally unilateral, they have a pulsing quality, and can be aggravated by physical activity and produce moderate to severe pain. Migraines are also commonly accompanied by nausea, vomiting, photophobia, and phonophobia. Tension-type headaches are very common with a lifetime prevalence in the general population, ranging in different studies between 30 and 78%. They can be broken down into frequent or infrequent, which occur less than once per month. Symptoms include bilateral pain with pressing or tightening in quality of mild to moderate intensity. The pain does not worsen with physical activity and is not generally associated with nausea. Cluster headaches are classified as having unilateral pain, pain and swelling in one eye, pain that radiates to the jaw, facial swelling, and a runny or blocked nose. I'd like to talk about assessment. So some of these assessments are used for diagnosis and classification of post-traumatic headache, and others are used for treatment outcomes. We discussed the International Classification of Headache Disorders in detail previously, so I won't do that again. The Glasgow Coma Scale measures the depth and duration of coma and impaired consciousness. It's used to determine the severity of the head injury from mild to moderate or severe. The Ohio State University TBI Identification Method interview is a brief, semi-structured interview assessing the frequency and mechanism of head injury across a patient's lifetime. Respondents are asked to describe a date and circumstances of head injuries. They are also asked to rate the severity of the head injury based on any loss of consciousness. Structural diagnostic interview for headaches is used to assess headache-related symptoms and determine headache classification. And then assessments that are used for treatment outcomes and are ones that we used in our randomized controlled trials. The headache impact test, the HIT-6. It's used to measure for headache-related interference and disability. And then headache diaries can also be used to assess the frequency, intensity, and duration of headache, as well as accompanying mood and sleep changes. I also have assessment in here for PTSD, since that's what our randomized controlled trial looked at, not just post-traumatic headache, but also PTSD. And so for the assessment of PTSD, we used the clinician-administrated PTSD scale for DSM-5, and that was to determine diagnosis of PTSD. And then for treatment outcomes, we used the PTSD checklist for DSM-5 for symptoms of PTSD, which are both gold standard assessments for post-traumatic stress disorder. I'd like to transition and talk about the randomized controlled trial that we conducted on post-traumatic headache and post-traumatic stress disorder. The post-traumatic headache and PTSD study was a phase 3, 3-arm randomized clinical trial that examined the efficacy of non-pharmacological interventions for headache and PTSD on headache-related disability. Participants included United States military veterans who met the International Classification of Headache Disorders 3rd edition criteria, modified for post-traumatic headache, and reported at least moderately impactful symptoms of comorbid PTSD. The sample was limited to veterans with persistent post-traumatic headache because these headaches are significantly more disabling and more difficult to treat than acute PTH, and because many individuals with acute post-traumatic headaches will later meet criteria for persistent post-traumatic headache. The exact mechanisms driving and maintaining post-traumatic headache remain unknown, and in clinical practice, the treatment of post-traumatic headache tends to default to traditional treatments of primary headaches, particularly pharmacological treatments. Evidence of predominant migraine characteristics in post-traumatic headache have led some to explore migraine treatments for post-traumatic headache, but prophylactic and abortive agents for migraines are not always effective. Also, long-term use of medication can worsen headache symptoms, resulting in medication overuse headache, which really led us to want to develop a non-pharmacological treatment. Non-pharmacological interventions are increasingly used to address complex pain conditions, but the vague definition of post-traumatic headache makes it difficult to tailor interventions. Post-traumatic headache often presents in the context of comorbid trauma, conditions like TBI and post-traumatic stress disorder. So treatment should include comprehensive non-pharmacological treatment strategies that can address both the post-traumatic headache and comorbid trauma symptoms concurrently. So in line with the need to address trauma symptoms, post-traumatic stress disorder plays a significant role in headache chronicity and intensity, and can play a greater role in maintaining headaches than that of more proximal causes like TBI. Thus, we felt that PTSD interventions may improve post-traumatic headache by decreasing PTSD symptoms. Broad spectrum non-pharmacological interventions, such as cognitive and behavioral therapies and CBT, can be uniquely suited to the indistinct post-traumatic headache presentation because CBT addresses the various dimensions of pain through multiple mechanisms, including coping, social activity, and comorbid mood symptoms. The present study was designed to test the efficacy of a clinic-based CBT headache intervention for veterans compared to a gold standard non-pharmacological intervention for PTSD. We used cognitive processing therapy in the treatment of post-traumatic headache. The two interventions under study were compared to treatment as usual in a large VA polytrauma rehabilitation center at the South Texas VA in San Antonio to assess the best approach for managing military veterans with comorbid post-traumatic headache and PTSD symptoms. And so our study objectives included reviewing the diagnostic criteria for post-traumatic headache and how existing ICHD-3 criteria conform to common post-traumatic headache clinical presentation, examine the research on effectiveness of usual care treatments for post-traumatic headache, and develop preliminary outcomes of a clinical trial targeting a novel, non-pharmacological intervention for post-traumatic headache. We utilized the HIT6 to measure post-traumatic headache outcomes and the PTSD checklist for DSM-5 to measure PTSD for the study. And here is our inclusion and exclusion criteria. And so our inclusion criteria included being age 18 and above, which is generally not a problem for veterans, U.S. military veteran or active duty service member, post 9/11 deployment, they had to have sustained a traumatic head injury, and diagnosis of persistent post-traumatic headache. Our exclusion criteria included a significant change in the nature of headache 6 weeks prior to screening, so they needed to be stable on the symptoms that they were experiencing. Current PTSD treatment to include cognitive processing therapy or prolonged exposure. They couldn't be diagnosed with a medication overuse headache. They had to be able to read and speak English at a 6th grade level. They couldn't have any psychiatric hospitalization 6 months prior to enrollment. We didn't enroll anyone who was pregnant because we know that the hormones related to pregnancy can impact headaches. They couldn't have any psychiatric problem that required immediate clinical attention, and there couldn't be any significant cognitive impairment so that they could understand the treatment. So here are our study interventions. We utilized a clinic-based cognitive behavioral therapy. We called it CCBT. The CCBT headache treatment is based on a cognitive and behavioral model of headache management. It consists of 8 one-hour sessions that participants are asked to complete in 6 weeks. And so participants are seen twice a week initially and then spread out to once a week. The 8 CCBT treatment sessions cover a variety of headache self-management topics and techniques, including relaxation training, identifying stress and analyzing stressful situations, planning for long-term stress management, solving problems that impact headache, dealing with thoughts about headache, specific headache coping skills training, and recommendations on how to maintain gains from treatment. Cognitive processing therapy is a trauma-focused treatment and involves helping patients learn to recognize and challenge thoughts related to their traumatic brain injury, in addition to the traumatic events experienced and their PTSD. Participants assigned to this treatment arm were asked to meet with a study therapist twice a week for 6 weeks for a total of 12 one-hour sessions. During this treatment, participants were asked to think about their trauma and about the meaning of the event, as well as their current beliefs about themselves and others. Topics such as safety, trust, control, self-esteem, and intimacy were discussed. Participants were expected to complete progressive worksheet assignments outside of session to practice skills learned in both CPT and the CCBT arms. Treatment as usual included participants assigned to receive treatment by their primary provider according to their established clinical treatment plan and recommendations. So treatment as usual included primary care and specialty care through the Polytrauma Rehabilitation Center at the South Texas VA. Treatment as usual often included medication management, palliative care, complementary and integrative health interventions, and interventional pain medicine procedures. Let's discuss a little more what led us to utilizing CBT for headache. The apparent mechanisms for change of CBT for headache are listed here. And so we have improving coping skills, particularly focusing on catastrophizing. We find that individuals who tend to catastrophize have poorer pain outcomes. And so teaching self-efficacy can really help improve pain ratings. Social support and having external coping resources often leads to reduced anxiety. We utilized biofeedback to help with the physiological response to stress. which increases an individual's perception of control. And so that falls really within a lot of the relaxation skills that we were teaching. And then also having pain acceptance and increasing mindfulness activities, which has been shown to be helpful for pain. Adherence is always a problem, unfortunately, when it comes to interventional studies. Behavioral therapies have level A evidence for primary headache, and so it's very strong evidence. And adherence rates range from anywhere from 50 to 80%, which isn't horrible compared to some other therapies. But we do know that adherence is highly related to outcome. We also know, and anyone that's worked with veterans know, that sometimes it can be really difficult to get veterans to adhere to treatment. And so sometimes that can be lower adherence when it comes to veterans. And adherence decreases with the duration of treatment depending on the definition. And so what can happen with times is that when the treatment is really long, oftentimes that adherence drops off over time. And so we had to develop therapies that were still effective, but not so long that we had a significant amount of dropout. Imputed mechanisms of CPT for headache include some common symptoms that you see with headache as well. And so looking at the avoidance, the arousal, trauma reminders, and anxiety sensitivity. We have direct effects of CPT on physical functioning. There's a mutual maintenance. We found that the headache can maintain the PTSD, and the PTSD can maintain the headache, and overlapping epigenetic mechanisms. Adherence for post-traumatic stress disorder treatments is also lower than we'd like. In veterans, it's around 60%. And once again, absolutely, the adherence to treatment affects the outcomes. The influence of adherence to PTSD treatment on pain and other somatic symptoms, you kind of get it can be a little bit difficult because you have an individual who has post-traumatic stress disorder and may drop out of treatment because of the trauma reminders and that it's very difficult emotionally. But you also have an individual who has a significant amount of pain, and there may be dropout due to that as well. Especially focusing on treatment can increase the headaches or filling out assessments and that sort of thing. And so we really wanted to maintain good adherence and keep close watch on folks that were dropping out in our study. This is what our study timeline looked like. And so you can see at the very beginning, we obtained informed consent and did our screening. Then we had our baseline and assessments. Our baseline and assessment appointments were fairly long, and probably for individuals who were not suffering from headaches, we would have probably been shorter, where most individuals there would have probably only taken about 2 hours to finish the assessments. But we found that individuals with post-traumatic headaches took much longer to fill out assessments and needed more breaks because all of the reading and the light in the offices sometimes brought about headaches. We had the treatment phase beginning in our treatment window. We had that extended a bit to make sure that we were able to get in the 6 weeks of treatment in case people were not able to make it for a week or a few sessions for any certain reasons. We had our post-treatment follow-up, and then we had a 3-month follow-up and a 6-month follow-up. All right, I'm going to talk a little more about the study findings. I already described all 3 domains of treatment and their support for post-traumatic headache. This slide really describes how the treatments were formatted for this study. And so the cognitive processing therapy was a standard 12-session CPT protocol. It was given twice per week. We did allow for ASAP sessions. And so an ASAP session would be if an individual came in and had crises that really needed to be addressed that put the CPT protocol on hold. We did not have any tailored headache content within the CPT protocol. We had the clinic-based CBT for headache, which included 8 sessions, and that was spread out over the 6 weeks as well. And so like I said before, is that the first couple of weeks, individuals would come in twice a week and then spread out until once a week session. The sessions really focused on managing headache triggers and problem solving, as well as relaxation and activity pacing. And then treatment as usual, as I said before, a lot of pharmacotherapies, interventional pain medicine, a lot of Botox is used for headaches and migraines, CGRP injections, complementary and integrative health, which included mindfulness, alpha stem, and massage. And this is our consort flow chart, and it was finalized the end of June, which was the end of our study. We had a target accrual of 192 individuals, and we ended up getting 193 in randomized. And our allocation across the 3 treatment groups were pretty similar. We had 65 allocated to the intervention, the CCBT. We had 64 allocated to CPT, and then we had another 64 who were in the treatment as usual group. These are our demographics, and so age in years. Our mean was 39 years, which is a little bit younger than you might assume a lot of veterans are, and so this is a younger population, individuals who had recently come back from deployment and were having significant post-traumatic headaches and oftentimes receiving disability and left the military due to the headaches. They most likely were male. The military status was almost 100% veterans. I think we had 1 active duty member sneak in. The PCL-5 total score was 48. Initial research suggests that a PCL-5 cutoff score between 31 and 33 is indicative of probable PTSD across samples. And then the headache impact test 6, the HIT-6, was 65 as a mean, and that indicates a severe impact due to headaches. So this was a population that was really suffering from their headaches while also dealing with PTSD. I previously outlined the ICHD 7-day criterion, but the study team really had concerns early on based on conversations with Brett Feeler, who published a lot in this area around 2010 to 2013. At that time, he recommended expanding the inclusion criteria to 3 months. We did so and examined our own baseline data to really justify that. And you can see here is the paper that we ended up writing based on our findings with the baseline data. To summarize it up, if we had only stuck with that 7-day criterion, we would have ignored about 1/3 of the veterans that we screened with post-traumatic headache that were attributable to mild TBI if we had used that old definition. Our study ended up finding no phenotypic differences between veterans meeting that 7-day criterion for PTH compared to those who met the delayed onset criterion. So we feel really secure in the fact that we ended up including those individuals because they are individuals that were suffering and needed the help as well, and there were no phenotypic differences between the 2 groups. So CCBT works for post-traumatic headache. You can see here we have the 3 lines. The orangish one is our treatment as usual. The black is for the CCBT, and the green line is for CPT. And so you'll notice a clinically significant change in the HIT-6, and that's what this is, the HIT-6 scores. And CCBT demonstrated a 2+-fold difference and clinically significant improvement. And so you can see here that over time, from pre to post to 3 months, individuals who received the CCBT had improvements with their headaches. It popped up a little bit from 3 to 6 months, but not very much. And then if you look at CPT, it's also interesting because it also seems to work for post-traumatic headache. And so In between pre and post treatment, there were definitely drops that popped back up at 3 months for some reason, but then dropped back down to about post-treatment levels at the 6-month follow-up. And then you can see that the treatment as usual is pretty stable over time. CCBT and CPT work for PTSD. So unsurprisingly, CPT works well for PTSD. It's why it's a gold standard treatment. But interestingly enough, so did the CCBT treatment. If you look here, you'll see from pre to post treatment, large gains with CPT. They maintained at the 3-month period, and then some symptoms popped back up at 6 months. Interestingly, the CCBT for post-traumatic stress disorder also helped. And so from pre to post, quite a drop, not as much as CPT, but still a drop. Continued to drop at 3-month post-treatment, and then leveled off at the 6-month post-treatment, almost to be the same as CPT. And then interestingly, the treatment as usual also showed some mild improvements. And so from pre to post, few symptoms popped back up at the 3-month period and then dropped back down just a bit at the 6-month. And some of that is because individuals within our study cohort sought PTSD treatment on their own through their PTSD clinical teams at the VA. And so as part of a treatment as usual, they're allowed to seek PTSD treatment, and some folks did so, which we tracked. So what this slide shows is that PTSD has a direct impact on headache disability. There is growing research showing that the direct effect of post-traumatic headache on post-traumatic headache disability is greater than the direct effect of TBI on headache. Most people talk about TBI as the most concerning factor in relation to post-traumatic headache, but it's actually likely to be post-traumatic stress disorder. So we created a novel strategy for replacing missing data for our study. We ended up contacting dropouts at the 6-month follow-up and assessed for the primary outcomes. And so we were able to give them the PCL5 and the HIT6. And then we asked for the reason of dropout. And we did this all over the phone. We used that information to manage for missing data. And so as you can see on this pie graph, there's multiple different reasons for individuals to drop out. And so one of the largest ones was travel, distance, and relocation, not wanting to make that drive to the VA and finding a parking space and those sort of things. Another was that the study just took too much time between filling out assessments and coming in for treatment. Some felt that the treatment was too difficult. Others developed a new medical problem that they needed to get taken care of. And then a very few number dropped out because they felt like the treatment was ineffective, which I think is really positive that that's such a small number. And then there was other 23%, which was more kind of a hodgepodge that didn't fit into any of these other categories. So based on our missing data, we've also broke it up into treatment intervention. And so folks were most likely to drop out from the CCBT intervention because they weren't able to travel or they had relocated. And a lot of those reasons why they couldn't travel was due to the pain of the headaches and too much time needed for participation, particularly the assessments. As you remember me saying earlier, is that the assessment process was pretty grueling and it was pretty long. And so individuals really struggled with filling out the paper and pencil test, the computer test. It oftentimes added a lot to their headaches, and if they had lingering cognitive difficulties due to the TBI, they just really needed a lot of time. And so oftentimes we were doubling or tripling the time needed to fill out assessments, and that really got to feel to be too much because we actually did not provide our study participants reimbursement, and so this was on their own time. CPT They felt that the CPT caused adverse reactions, and so oftentimes that was in the area of feeling like their symptoms were worsening, which anyone who's worked with PTSD patients know that there's kind of a phenomena of getting worse before you get better. And so oftentimes individuals were not willing to see that out and dropped when their symptoms initially increased. They felt like there was not enough focus on the headache. It was too much PTSD. They really wanted to focus on their headaches. And when they were randomized into the PTSD treatment arm, were dissatisfied, or other new medical problems developed. And then the treatment as usual, difficulty traveling due to disability. And so once again, that was to come in and do the assessments. We also obtained blood draws from individuals, and so to come in to do that. And they felt treatment in this arm was not helping with the headache or the PTSD because they were doing the treatment as usual. We did offer all of our treatment as usual participants that they could come back in after the 6-month follow-up, and all assessments were done, that they could join either the CBT or the CPT intervention if they'd like. I'm going to go over the conclusions before I end today. And so the 7-day latency definition for post-traumatic headache should be expanded to at least 3 months to really incorporate all the individuals that are suffering with persistent post-traumatic headache, especially since, typically they're no different than the individuals at the 7-day mark. Post-traumatic stress disorder is an important part of disability associated with headache and should be addressed as part of treatment. A manualized non-pharmacological intervention for post-traumatic headache can significantly improve both post-traumatic headache and PTSD concurrently. There's always a question of which do you treat first, but they can be done simultaneously, at least in this population. This is a large randomized control trial, and more work should definitely be done to generalize the findings. And so we were recently funded through the DoD to expand our study and have a multi-site trial. And so we will be conducting this treatment along with incorporating more telehealth so that we can reach individuals who are unable to travel to the VA, especially since that's the feedback we got from individuals for why they dropped out. And it'll be across 3 different DoD sites and 3 different VA sites. And we'll look at the treatment interventions on a larger scale. A manualized post-traumatic stress disorder intervention improved headache and PTSD, but headache improvements were less than those with CCBT. Mechanisms of post-traumatic headache are still unknown, but psychosocial variables are of significant interest, not just post-traumatic stress disorder, but depression, anxiety, substance use. We also have ongoing biomarker studies that we're really starting to get into the data. And so we're looking at endocannabinoid systems and inflammatory systems because we were able to obtain blood draws from our participants. And so those are some of the things that we'll be focusing on in the future. So I would really like to thank all of you for being here and listening to this presentation. I really appreciate it. If you have any questions or comments, please feel free to reach out to me. My email address is listed here, as well as my husband's as well. He'd be happy to answer any questions about the post-traumatic headache study also. Thank you for your time, and I appreciate it, and I hope that you all are well and have a great day. Thank you.